right. Welcome all to the next installment of the Brain and Behavior Research Seminar Series. It's my pleasure to introduce Dr. Erin Meier as our speaker today. Dr. Meier is currently an assistant professor in the Department of Communication Sciences and Disorders at Northeastern University and the director of the Aphasia Network Lab. Dr. Meier is special to us here at the Center for Brain Recovery because she received her PhD working with Dr. Erin back when we were known as the Aphasia Research Laboratory. Dr. Meier also completed a postdoc fellowship at Johns Hopkins with Dr. R.G. Hillis. The goal of Dr. Meier's work is to maximize functional recovery in people with aphasia by better understanding the links between the brain, language, and behavior in real-world context, topics I'm sure we'll hear much more about during her talk this afternoon. Please take it away, Dr. Meier.
All right. Thank you so much for that lovely introduction, and thank you for inviting me here. It's always fun to come back over to BU, old stomping grounds. Although I have to say, much different stomping grounds physically than when I was here. All right, let me go ahead and share. All right, I'm going to share sound too. Okay, great. Can everybody see that? Oh, but that's not. I need to switch into presenter mode. There we go. All right, perfect. Okay, well, so when Maria asked if I wanted to present to all of you online and here in the room, I thought some of my research that I've begun at Northeastern, what would be of most interest, and this is kind of one of my main lines of work is trying to increase, I would say maybe incrementally, ecological validity of aphasia assessment. And so when I say aphasia assessment, I mean language assessment, but also when we think about looking at the brain and trying to make links between brain activity and communication. So what I'm going to talk about today are a couple of studies where we're trying to leverage newer technology in order to this end for this goal. So this is what I'm kind of planning on is I'm going to do a super brief introduction. I want to talk about a couple of studies that we've had in my lab wrapping up, one that's ongoing. So this is kind of what I'm thinking, but if people have questions or if you want to chime in at any moment, I'm happy for it to be more of kind of a back and forth rather than me just blathering at you for 40 minutes or so. Okay. So to get started, I'm going to kind of frame my thinking here in terms of a model that I think we're all really familiar with. So this is the WHO ICF model. So this is a model that can be used to understand the impact that health conditions like a left hemisphere stroke can have on a person's life who has that condition. So I'm not going to walk through the model because I think a lot of people are familiar with this model, but you can read some of the examples that I gave. And the idea here is that these different variables, kind of factors that can be affected by a health condition can collectively impact somebody's quality of life. And so this model is often used to try to help us understand not just the impacts on somebody's life, but to think about assessment and treatment for example, stroke survivors. And so those of us who do clinical research, some of us are also speech pathologists, we focus a lot on this level, right? The impairment level, otherwise known as the body functions and structures level. So this is, the damage that happens to the brain after a stroke, changes in brain function, as well as the associated language and linguistic deficit. So this is where we often assess, this is where we often treat. And the assumption is that this is going to happen, right? Is that in treatment that we're going to see generalization to these other levels, or that from assessing language on the Boston Naming Test or the Western Aphasia Battery, that gives us a window into somebody's everyday communication. So I think we all know that those assumptions don't always play out. And not only is there, I think, more work done on these other levels, right? We're all kind of heading in the direction of targeting activity directly, assessing functional communication, for example, quality of life. But there's also now, I think, more discussion about how these other factors, so personal factors, individual differences, environment, context kind of plays a role in what we do. And so what I'm going to focus on today are kind of these two boxes in orange and how that relates back to these questions I'm trying to address in my research. So this silly cartoon kind of conveys this notion in a different way, especially about assessment. So when we assess stroke survivors, often, in the clinic, in our clinical research, this is the context in which that happens, where you have the clinician that's seated on one side of the table, the clinician's holding a manual. That's what that rectangle is. My artistic skills aren't great, but so and ask the person with aphasia to name pictures, for example, right? And it's usually via this interaction where it's one-on-one, the client or the patient and the clinician, where we purposely try to minimize noise, minimize distractions, and that's good for kind of optimizing the testing environment, but that's often not the case for everyday life, right? It looks more like this, where you have say that instead of a quiet clinic setting, you have somebody with aphasia trying to tell their partner that they need to get their coat from the coat rack before they leave the restaurant, right? And so there are all of these other kind of real world factors that we're not capturing when we assess in this kind of traditional way. So there might be competing linguistic, non-linguistic noise. If there's music, if there's chatter around, maybe the waiter comes over and interrupts the person, as they're trying to tell their partner that, maybe they're trying to navigate their way out of the restaurant, et cetera. So I think that, makes sense. It's not necessarily rocket science, but then the question is there a discrepancy between the way that we kind of traditionally assess using a variety of measures in the clinic setting and what happens in everyday life. And then this can kind of be turned into a bit more of a basic science question of, what are the brain regions, the brain networks that are responsible for everyday communication? And is there a difference between, what we kind of have as our traditional paradigms and paradigms that are a bit more ecologically valid? All right, so that's setting the stage. So what I'm going to do is I'm going to expand on a paper that I shared with the group where we are presenting some very preliminary data from a study that we did using ecological momentary assessment. So these are a little bit more complete results than what you all read so far. I'm going to back up a second, but I'm not going to belabor these points because I think everybody, certainly in this room, I think people online also know this. But just to emphasize here, what I'm focusing very heavily on today is post-stroke anomia. So anomia is arguably the most common deficit after somebody's had a stroke, and it's typically something like this, right? Where somebody knows what they want to say, but they just can't retrieve the word. So one of the facets of post-stroke anomia, the thinking by a few people is that post-stroke aphasia, post-stroke anomia it's an access deficit, it's not a storage deficit. And so that was kind of nicely depicted in a paper by Meier and Britt from a handful of years ago now, where the idea is that in post-stroke aphasia, the word representations themselves haven't been destroyed. So if you look at the claw machine all the way to the right, that looks like the claw machine of the typical adult, the neurologically healthy adult. It's access to them that has been impaired. And so that's typified, shown by this broken claw. And so the way that manifests is, in this variable access to words that folks with aphasia have. And so if you work with people with aphasia and they say, oh, I have the word, oh, now it's gone. And so it's this back and forth where it's variable access. So if that's the case, and if we want, and there are a handful of paradigms have been used to test that that's the case. But if we want to have a fuller picture about that over time, there are a few ways we can do that. Sometimes in treatment studies, we do assess the same item multiple times, but in clinical practice, that's pretty much never the case. So usually it's the case where skills are assessed once in a single administration of a test, and we say, okay, that's the extent to which that we can kind of get a picture of their impairment. So there are, as I was brainstorming, ways that we can get closer along the continuum of kind of getting a handle on real world manifestation of language deficits, word retrieval deficits. One way to tackle this issue as well, I just so happened to have a conversation with Stephen Antilli, who is a computer scientist at Northeastern who does a lot of ecological momentary assessment work. And I was really intrigued, and that sort of sparked this project. So EMA, or ecological momentary assessment, EMA for short, it's a method where people use a smart device, typically a smartwatch or a smartphone, and it prompts somebody throughout the day to do something. So answer a series of questions, indicate their mood or indicate their pain level, for example. And that happens several times over the course of the day, and then for a period of time, so weeks, days to weeks to even months. I'm going to say, I'm getting a message that somebody is requesting a remote control of the screen, so I'm going to say no. Okay. With EMA, it's been used quite a bit in other health research, but there've only been a handful of studies in post-stroke aphasia. Those studies are promising, but there's still a lot that we don't know about the method and the feasibility of doing something like this with people with aphasia. So in this study, that's actually where we wanted to start first, was just to focus on feasibility. So we have this novel protocol that relies very heavily on technology and technology that was unfamiliar to some of our participants. And so before we deployed this with our participants, our team addressed everything there in blue. So like we had to figure that out first. And then part of our study was actually there in green. So we wanted to get an idea about feasibility of this protocol. And so I'm going to kind of focus there first. But then this is what we were thinking, or what I was thinking, that this ecological momentary assessment, we did this via smartwatches, might be able to capture something, I would say, different about anomia than the traditional way that we do assessment. And I specifically thought that word retrieval would be worse via EMA than it would during traditional assessment. And we had a few ways where we controlled the various factors that might confound being able to do that comparison. So I can talk about those if people are interested. But that gets into a little bit of the weeds, but happy to talk about that. Okay, so first, again, like I said, we focused on feasibility. So we wanted to determine relative feasibility between people with aphasia and controls who were assigned to do one of two EMA conditions. And I'm going to talk about those conditions in a couple of slides. And then we wanted to understand what personal factors affect feasibility. Our last aim was kind of the more clinical question, the clinical aim. So here we wanted to evaluate the magnitude of anomia severity differences between the traditional and the ecological momentary assessments. All right. Okay. So this was a 5-week observational study. So we enrolled 16 folks with aphasia and 16 controls. During the first week, all participants did the same activities. And so we did a handful of behavioral assessments in the lab, and that included a picture naming probe that was done in that traditional SLP assessment format. So the picture naming probe included the pictures from the Snodgrass and Vanderwert picture sets, if people are familiar with those. And that's 260 pictures. We whittled that down to 108. For folks with aphasia, we tried to get half the items that they named incorrectly during this first assessment, and the other half that they named correctly. And that was their EMA set. So that's what they actually got during the 3 weeks of EMA. Healthy controls were then demographic matched to the participants with aphasia, so we kept the word lists even. During the second session, that was devoted primarily to smart device training and EMA simulation activities. This all hinged on people being able to manage the devices, know what to expect from the protocol. And so we spent quite a bit of time on that in the session, and then we sent home materials with the participants. The EMA simulation activity was their opportunity to demonstrate that they knew what to do, and our opportunity to retrain people if needed. And as I'll show you on the next slide, it was pretty simple. And so everybody was able to follow it fine. After that, folks were pseudo-randomly assigned to one of two EMA conditions. And then week 5, they did that traditional SLP assessment, picture naming probe one final time. and then they completed an exit interview. All right, so hopefully this works and hopefully people can hear it. So I think the easiest way to kind of demonstrate this is to play this little video. So this is an example trial from this one item EMA condition. That the sound is not coming out. And I'm not sure why.
Unmute yourself once, but I can. People online here.
Maybe. I can also just describe it. So what happens is that the smartwatch vibrates, and then it also does a little chime. And then the first thing that people see is this screen, this ready to name a picture screen. And that's important because if people pushed yes, then as soon as the picture appears, we start recording their audio. So we wanted to give people the opportunity to opt in or opt out, because we're recording them as they're going about everyday life. So people were did either one of these conditions. So in the 9-item EMA condition, after this ready to name some picture screen, if they said yes, they saw 9 pictures back to back that they were asked to attempt to name. And then in the 1-item condition, it looked like the video. So they were asked to name just 1 picture at a time. So all participants were scheduled to name the same number of pictures every day, so 36 pictures. So that amounted to 4 prompts for the folks in the 9-item condition, 36 separate prompts for people in the 1-item condition. And that, if you do the math, they did it for 3 weeks. That's 756 picture naming trials for over the course of the experiment.
But everybody saw it 4 times a day.
So for the people in the 9-item EMA condition, they got 4 prompts per day. So it was 1 prompt every 2.5 hours. And then in the 1-item condition was 9 prompts every 2.5 hours. And so there, as I'm going to show next, actually, is we calculated compliance using completion in this way, where we took the number of yes responses and divided it by the number of scheduled prompts. So here, it's kind of stacked against the folks in the 9-item condition, right? So the denominator for people in the 9-item condition is 84, if you do the math, whereas the denominator for people in the 1-item condition is 756. And so if you miss a prompt for people in the 1-item condition, there's much less cost than people in the 9-item condition. Since you asked, the reason why we did that is that the way that EMA is often done is by prompting people less throughout the day, and you ask them to do more for every prompt. And Stephen Antilli, my collaborator on this, he's kind of pioneered what he's called this micro EMA method, where instead of prompting people less and asking them to do more, his theory is that if you just prompt them more often, but it's super fast, and you don't have to kind of like get disrupted, that response rate will be better and you'll have less missing data, that sort of thing. And that's what he's found, and spoiler alert, that's also what we found. So that's one of the reasons why this was built in, but it also kind of gives a nice opportunity to look at, we can do things which we haven't yet, of looking at the surrounding semantic similarities between items within, like a 9-item prompt, that sort of thing, to see if that has any effect on naming. Okay, so completion is a bit different the way that we calculated it. So this is also a feasibility measure, but this is the number of yes responses divided by the number of delivered prompts. So there can be a difference between delivered and scheduled because of tech issues. Somebody forgets to charge the smartwatch, and of course the prompt's not going to be delivered. We also spent quite a bit of time trying to get feedback from participants just about what they thought about the protocol, and how burdensome it was. So every week, at the end of every week, people did a very quick Qualtrics survey, from which we were able to get measures of perceived burden. And then finally, for our last aim to actually answer the clinical question, we transcribed and right now have accuracy coded all of the naming data from the traditional assessment and EMA and EMAs. It's a lot of naming data. And so we're also looking at response times and error types, but that just hasn't been baked yet. We're not quite there. All right. Does that make sense? Good so far? Okay. All right. Okay. So in terms of our feasibility results, So, our sample, this is a pilot, so our sample is fairly small when you kind of divide it up by participant group and by EMA condition. So what we first did is we looked at differences between controls and folks with aphasia and kind of ignored EMA condition. And then we compared folks who did the 1-item condition to people who did the 9-item condition and kind of ignored participant group. All right, so this plot shows compliance results. So obviously if somebody's 100% compliant, that means that they responded to 100% of all of the prompts that were scheduled. That's pretty much impossible. That never happens in an EMA study. And these numbers look pretty good. And I think what's maybe even more important is, or equally important, is that we don't see any differences between folks with aphasia and age-matched controls. What we do see is a trend towards higher compliance for people in the 1-item condition versus the 9-item condition. As I explained about how the prompt system works, that maybe isn't very surprising, but this reinforces maybe the benefits of doing this micro EMA. So you're prompting people a lot more, but there's a lot less missing data. And then the completion results are actually pretty similar. So again, we don't see any difference between controls and folks with aphasia. Here, the averages are higher because now this is delivered prompts, and so it kind of takes into account any tech issues. And then again, we see this trend towards higher completion for people in the 1-item versus the 9-item condition. And then in terms of—
Can I ask a quick question? Sorry.
Yeah.
When they're prompted,
Yes.
are they ready? I mean, it's the same prompt for 9 items or 1 item.
Yeah, it just is, are you ready to name a picture versus ready to name some pictures? Yes.
If they say no, right?
Yeah.
Because like they're busy that moment.
Totally, yeah.
When does it come back?
Yeah, so if they tap no, or if they just don't respond, period, then they're re-prompted 5 minutes later.
Right.
And if they again don't respond, or they again say no, then that
becomes non-compliant.
Yeah, it's missing. Yeah, exactly.
But the first time is not missing.
Right, exactly. And we did have quite a few re-prompts. The nice thing about doing something like this is we have log data for everybody for, the 21 days that everybody did this. And so sifting through that is kind of a beast also. And we actually saw that there were a higher number of re-prompts as people were going on and doing the study. But people, even though they were delaying responding, they were still responding, and with a pretty high response rate.
I suspect with the 9, they could get interrupted during the 9.
Yeah, I mean, they could. It's interesting because, so what I didn't say, I don't think, is everybody had up to 10 seconds to name the picture. And so that meant for people in the 9-item condition is that it was a 90-second recording, up to 90 seconds. If people were able to name the picture faster than that, they could tap on the screen to go to the next item. But especially for some of the folks with aphasia, with more severe aphasia, it's a 90-second recording. So you can hear in the background, sometimes somebody's spouse going, no, respond to the watch, and so that's something that we didn't really account for, and we can't really account for. And then there were also some where, like you said, you kind of, intuited, they respond to the first few and they think they probably just tapped really quickly to get it off the screen. But that didn't happen too often. I think people just, and this is also based on the exit interview, which I'll talk about a little bit too. If they were doing something where okay, I really shouldn't respond. And that's something that we talked about a lot. It's please do not feel obligated to respond. If you're driving, for example, please do not respond when you're driving. We made sure that we kind of suggested some scenarios to people during that training of this is not a great time to respond, or if you just feel like you're around people where you don't feel it's appropriate, that's okay too.
Okay, thanks.
Okay, so the perceived burden results are from that weekly culture survey that people did at the end of 3 weeks of EMA. The burden ratings didn't change over time, so we just summed all of them to get a summary score. So people rated these on a Likert scale from 1 to 5, where 5 is best. So 5 means they strongly disagree that the protocol was burdensome. So here we found, again, no differences between folks with aphasia and controls. And we also actually didn't see any differences between people who did the 1-item and 9-item EMA condition. And the averages here, 3.7, 3.6 or so, that means that people basically felt neutral, or they felt that they disagreed about it being burdensome, which we appreciated. All right, I might just skip the interview feedback. All this is maybe my favorite part of this whole thing, just for time's sake. But the upshot is that in the interview, I think that's a really important component of this study, because anything like this that relies really heavily on technology, a new technology, getting participant feedback about the user interface, the protocol, like what they liked, what they didn't like. Basically, people felt pretty positively about it. This quote that you can see on the screen here is from our first participant with aphasia who did this, and basically saying, he's like describing what he had to do. He's like, it's pretty fine. And that was like the sentiment that we had from a lot of people. I'm just going to kind of go through this. One of our participants, actually a few participants with aphasia, highlighted specific items they kept on getting stuck on. He actually means artichoke, not avocado, FYI, but so that was kind of interesting. And then of course we also asked them what they didn't like, what they would have wanted to change. One thing that I just want to mention, because this is really important if you're using a commercial technology, which I'm not going to mention the watch that we used, but so this isn't, you can do EMA a few different ways. And one way is you can have it, have somebody's own device alert them. We created the app, and I didn't create it. Stephen and his PhD student created the app. And so, we weren't able to use people's own devices or like an off-the-shelf like EMA app to do this. And so we had to use a certain type of smartwatch that had some battery life issues. And it wasn't just us, like we went on like Reddit forums and there were tons of people complaining about it. So that's just something to keep in mind. It's also something, I'm always thinking, okay, is this clinically feasible? And obviously right now it's not. So we're not gonna just be giving people with aphasia or folks, smartwatches and using something like this. So this is kind of early days first steps. Okay. So in terms of associations or predictors of feasibility, one thing that we really liked is there is no relationship between aphasia severity and compliance or completion. I didn't show you a table with participant information, so I do want to disclose that we had a lot of folks with pretty mild aphasia and anomia. We had a couple of participants with more moderate to severe aphasia, but nobody that you'd think of as having kind of the classic global aphasia. So just want to mention that. Across the entire participant group, we found that higher compliance was associated with older age, a little surprising, and better inhibitory control. We think probably what's going on here is that some of our younger participants were working part-time during the study, and so maybe that was sort of a mediating factor. The inhibitory control finding I think is kind of interesting. So maybe people who are just better able to kind of suppress distractions are like, oh, I can actually respond to this. So that might be what's going on. We also found that higher perceived burden was related to higher completion, which I think also makes some logical sense. So people who are, responding at a higher rate when they get the prompts are kind of feeling like it's getting more burdensome as they're going about it. All right, and then this is kind of the meat. This is the crux, I would say, although I think we're only halfway there in terms of results right now. So in terms of accuracy differences between the EMAs and traditional assessment, this a little overwhelming plot shows the time series data for each day of EMA, plus for folks with aphasia, the 3 times they did the traditional SLP assessment naming probe. So obviously the frequency at which we're assessing people in these 2 conditions is not the same. But I think the results are still kind of interesting. So the colored lines indicate are like the single subject results, and then the black lines are the average, the group level results. So what we saw using a linear mixed effects model was that accuracy was significantly lower during EMAs. So that's the black solid line than during traditional assessment, which is the dashed line. And that was an average of 9%. And that was actually a pattern that 13 of the 14 participants exhibited. Okay, so what do we think we know from this? So I think there are a few like kind of take-home messages that I think are promising and some big unknowns. So first and foremost, I think the feasibility results are pretty convincing, but please, I'm happy to have a conversation about that. One thing that we saw is that, completion and compliance was similar between folks with aphasia and healthy controls. And it's actually pretty consistent with what's reported in kind of the extant EMA literature. And we also, although we found some relationships with feasibility and personal factors, we didn't find any feasibility metric was related to aphasia severity. So I think that's promising in that folks with aphasia can be included in these kinds of EMA studies. I think should be. There have been a handful of EMA studies in stroke survivors where people with aphasia haven't been included. We also found right now that word retrieval was worse, meaning that folks were less accurate during EMAs than during traditional assessment. But there's still a question of why. So, there could be a lot of things going on. You can think of, all right, maybe it's because they're in the middle of something and they had to shift sets and then get into a different cognitive set and name, and that was tough for them to do in the time frame. There could, or maybe it was because there was too much background noise, or maybe they were trying to do multiple things at once. So what we don't know is what was really happening in the moment when they were doing EMA. So that's something that we want to look at. And we also haven't looked at relationships between those personal factors in our results yet. But that's, future plans, short-term future plans. And then in terms of long-term, as I mentioned, this isn't something that's like can be packaged and, put into a clinic at this point. So we're kind of here, and there's a lot more work that needs to be done, probably expanded beyond just naming into maybe other tasks. Obviously, something that makes this kind of thing accessible to patients who've just had a stroke. So, a lot of work along this clinical translation continuum that remains outstanding. But this is where we're kind of at right now. Okay, so this is now like a hard shift to something very different. I don't know, I know it's already a little after 4:30. Anybody have any questions or comments about this? That's a little like Julian. Okay, perfect. Okay, so as I mentioned, we're trying to do some FNIRS work, so I'm really eager to get some feedback from people in this room and even folks online. I don't know who's in the Zoom room about ways to increase ecological validity of our imaging that we do. And so this is a task that we have some pilot data on, and we're calling it naming a noise. And so this is kind of the premise or the motivation behind this, which is that, we've, as kind of a scientific institution, we have all of the data from all of these paradigms where we're asking people to do things like make semantic judgments or decide if a couple of non-words rhyme, that sort of thing. And so we know about, the representation of linguistic systems and language like in the brain, or maybe we do. But this is, a meta-analytic data from nascent for the search terms semantic, phonological, and syntactic. So then the question is, does this actually tell us something about everyday communication, or what other parts of the brain would need to be recruited for that? And so earlier, I kind of set the stage is, okay, so if everybody's everyday communication, right, probably taxes not just language, but other cognitive systems. So then we turn to, this conversation about, the difference between language network and other brain regions for accomplishing these kinds of tasks. So this, of course, is from Ev Fedorenko and Sharon Thompson-Schill from now 10 years ago, but this is the framework generally that has driven, Ev's work and the work that you all have done with her is, so the question is, to what extent Our cognitive control regions, or these multiple demand regions, are important for other cognitive processes or when things get hard, for language processing. And that's certainly a big open question still for folks with aphasia. And that's just if you have your garden variety language task, right? You know, that semantic match task or that non-word rhyme task where you're not imposing these other additional demands. And so if something is even more challenging than regular language task challenge that people with aphasia face, how does that manifest in the brain? So that's what drove this pilot. And this is a task that we've just done in a handful of participants with and without aphasia. And so here we're testing something very, very specific, which is the extent to which background noise might impact word retrieval ability. So both in terms of accuracy and response time and what that would look like in the brain. So in terms of left hemisphere language, cortical activity versus right hemisphere homologs versus recruitment of domain general brain regions. And so with this, we are thinking that response times would be longer and accuracy would be lower for folks with aphasia, but probably not controls because of the nature of the task during these background noise conditions compared to just silent naming or word retrieval in silence. And that brain activity would be greater in domain general brain regions for background noise conditions compared to silence for both groups perhaps, but the magnitude would be greater for people with aphasia. All right, so that's the setup here. Before I get too far along, I might just very quickly introduce FNIRS mostly for people on Zoom who might be unfamiliar. But I think there's a growing realization that, fMRI can tell us a lot of things about the brain and how we process language, but sometimes other tools can also be used, like FNIRS, for example, that in more ecologically valid paradigms. So paradigms that mirror things that we do in real life a bit closer than the paradigms that we use in fMRI. The other thing is that FNIRS is less expensive than fMRI, which is always nice for those of us who do this kind of research. And the system that we have, like many, it's wearable and portable, so that just increases the flexibility. So it's still not used a whole lot, although I think in the last 5 years, there are more and more people who are using FNIRS, not just with stroke, but specifically with post-stroke aphasia, which is exciting. I'm not going to delve into this, but this is just to give people kind of a very brief overview about what FNIRS is actually measuring. So very briefly, FNIRS tells us something similar that fMRI does, which is changes in the hemodynamic response. Specifically, if you have a task like naming pictures, what happens in a paradigm like that, if there's an increase in neural activity, that changes brain metabolism, and that could be measured by changes in oxy and deoxy hemoglobin, where we would expect to see an increase in oxyhemoglobin and a slight decrease in deoxyhemoglobin. That is done by placing a cap like this on somebody's head that has sources that emit near-infrared light that travels in kind of this characteristic banana shaped path. And oxy and deoxyhemoglobin chromophores in the brain absorb light in the near spectra, reemerges to the head surface detected by the detectors, and you can then do a lot of calculations to get these oxy and deoxyhemoglobin measures. All right, so that's a brief FNIRS primer. What we've done so far with this task, so we've just done it in a handful of participants with and without aphasia. So 9 folks with aphasia and 10 healthy controls. And so they've completed what we're calling this naming and noise task. Participants were generally matched for demographics, and then there's a wide range of aphasia severities in this quite small sample, including a couple of people who actually test as not aphasic by the WAB, that's NABW, but still endorse language deficits. And then all the way to people with quite severe, kind of on the lower range of qualifying as having Broca's aphasia, and somebody who's kind of on the cusp between conduction and Wernicke's, just to give you sort of a sense. So the peak area of damage is shown there by the crosshairs and the folks who've done this sample. So it's kind of interesting. We have a lot of people with pretty posterior lesions, or rather a lot of people with posterior damage. So here in the left parietal lobe. But one thing that I would love to talk to people in this room about, if people on Zoom have some thoughts, is, what do you do with the lesion FNIRS data? That's still, a kind of a topic that I'm interested in discussing. This is the FNIRS task. So this naming and noise task, where people, it's a block design, fully randomized within block, where people are seeing the same pictures in each condition. So there are 3 conditions. So there's a speech noise condition, a non-speech noise condition, and a silent condition. So their naming in every condition is just if there's background noise or not, and the type of background noise differs. I realize now that because I don't think I can play my audio, I can't play these sound files. I'll just describe them very briefly. So the one thing to, I think that's important here, or 2 things that are important, is that the speech noise condition, there's speech in the sound files, but there's also other kinds of background noise, and you can't tell what people are saying. So it's more along the lines of like energetic masking rather than informational masking for people in the know about those terms. And we didn't kind of titrate the noise level to people's hearing levels in this study, because kind of debated that. But one thing is that in the real world, you can't do that, right? It's just the noise that you have. And so we had the same decibel level for every participant, which was actually quite loud. And I think that's the 2 main things I want to say. People did object naming and action naming, especially now. For the sake of time, I'm just going to present the now naming results. I actually think they're a little bit more confusing than the action naming results. So maybe that's a good thing to present and kind of talk through. Okay, so before we get there though, I just want to show the montage. So we collected data with 2 daisy-chained NearSport 2s, 8x8 NearSport 2s. And so our montage included 44 long and 8 short distance channels. And we have, pretty decent coverage, I would say, of kind of your classic Parasylvian language regions and right hemisphere homologs, and also some prefrontal coverage. And if you overlay the masks from, this is Ed Fedorenko's language and MD masks, you see that we have some pretty decent coverage in kind of the classic language regions and also in domain general regions. So this is the pre-processing pipeline. So we used Homer. And so we followed kind of classic steps. We did motion correction, detection and correction using Spline SG. I actually talked to Miriam a little bit about this because we tried Wavelet, we tried Spline SG, tried some different parameters. And, this is a task that involves overt speaking. And so motion artifacts are certainly present, I would say. And so kind of ways to optimize the pre-processing pipeline, I think are still ongoing. Anyway, so we also did high pass, low pass filtering, your OD to concentration conversion. So we estimated the HRF with a GLM, and then we also did image reconstruction in Atlas Viewer. So I was kind of debating whether to show kind of like the time series results, the block averages, or to show the image reconstruction results. I landed on the image reconstruction results, although I do think those are a little bit harder to interpret. What's wrong?
Oh, okay. Somebody can't see the slides, but I don't think that's true. So.
Oh, okay. Sorry, I was like, oh, what did I say? All right. So first, we just wanted to look at behavior. And again, like I'm presenting 2 studies that are still kind of like, they're hot off the press, or maybe like not even like in the press yet. So we're looking at accuracy, but also response times. We're not finished with the response time calculations. As expected, we saw that people with aphasia produce significantly fewer correct nouns and verbs in healthy controls, as you would expect, as you would kind of hope based on the sample, but we didn't see a group by condition interaction. I think there are a couple of reasons for that, which I'll talk about in a couple of slides. Controls are at ceiling for both noun naming and verb naming, as you would expect. And even the folks with aphasia as a group are doing pretty well. Granted, though, we have a huge range of naming ability in this very small sample, but here you can see that there aren't any differences between conditions and accuracy between these different background noise and conditions. Okay, so these results are changes in oxyhemoglobin for noun naming. So here I'm showing main effects. So basically main effects for the condition of interest versus rest, essentially. And this is over a quite long range, 5 to 30 seconds. And so this is for controls. So for noun naming, there's these widespread increases in oxyhemoglobin, really bilateral and in both hemispheres. So you see that there's mid to posterior temporal brain activity, some kind of superior, inferior frontal activity in the left, also posterior IFG in the right, and then even some dorsolateral activity in both hemispheres. A little less left lateralized than I would have expected. And that kind of still plays out in the noise conditions too. So an interesting kind of decrease in oxyhemoglobin in temporal regions and IFG, kind of more ventral IFG in the left and anterior in the right. Here, this is a bit more left lateralized. And then here for speech noise, we actually see some reductions in oxyhemoglobin compared to rest, which I have maybe a couple of theories about that, but would love to talk about that at some point. But the upshot is that we actually don't see any differences between conditions for language and MD ROIs when we analyze the data outside of Homeware and Atlas Viewer. For folks with aphasia, I think this is maybe a little bit more of a confusing story, or maybe half-told story, I would say. So here, there's a lot of blue, and I should have explained this for people online and those unfamiliar with FNIRS. Red means an increase in oxyhemoglobin. Cooler colors mean a decrease in oxyhemoglobin. And so for patients, we see, there's this bilateral increase in oxyhemoglobin in IFG. And then also, I think kind of interesting, like in the left auditory region. But otherwise, as a group, we see these decreases in oxyhemoglobin. And then there's a bit of a change for the non-speech noise condition, where we do see some increases in oxyhemoglobin as a group in more posterior temporal regions in both hemispheres, a bit of a higher, similar increase in oxyhemoglobin in right IFG, but then kind of similar to control, we actually see more widespread like reductions in oxyhemoglobin for the speech noise condition. So, but when you look at, statistical comparisons between these conditions, we actually don't see any differences, again, between conditions and language ROIs or MD ROIs. So right now, I think there's a lot of still needs to be done with this task. And I have some thoughts, but again, would love to talk this out with people. Turning first though to the behavioral results, I think there is a pretty obvious explanation for why we don't see any condition effects. And I think that's kind of for two reasons that interact with each other. One is that these are really, the items are very high lexical frequencies. We're talking about like chair, bed, pencil, like really, really common items. And so our participants, we have 4 folks who have really, really mild aphasia and anomia who actually don't test as being any different than controls in their behavior according to Bayesian tests of deficit. And then we have 3 people who have very much more severe anomia and aphasia. And my thinking on this is that, for the people that it would matter most, it would probably be somewhere in the middle. Like the people who have very mild aphasia and very mild anomia, they're doing pretty well, like no matter what's going on, especially this is just background noise. It's not linguistic in nature. And so there's not that kind of interference. And so they're able to just name consistently and kind of consistent, consistently well. Whereas the people with more severe anomia are just struggling kind of like no matter what. That's my theory at least. And then just kind of summarizing this again, controls seem to have this bilateral activity in kind of all regions for most of the conditions compared to rest. So we don't have a low level baseline like a scrambled picture condition. Whereas for folks with aphasia, we do see these kind of like widespread reductions in oxyhemoglobin. So, you know, it's putting together 9 people with aphasia. It's not a huge sample, and they're really variable in terms of language profiles, also lesion profiles. And in this analysis thus far, I haven't controlled for lesion in any way. So we haven't like toggled off channels for lesioned areas. So maybe there's some effects there, and just kind of collectively, that's what's driving it. I think also there's still some lingering motion artifacts that we need to look into, but those are all things that we're looking at. Right now, you know, I don't even maybe want to say this bullet point because, you know, I think this is maybe TBD, but since we don't see right now a difference between conditions in terms of level of brain activity, it kind of suggests that there's no kind of effect of background noise on word retrieval. But I think that's kind of premature to come to that conclusion, considering, you know, the additional work that we have to do with the data set. It is a very small sample. So, you know, take that with a grain of salt. So there's quite a bit that we're still doing, but these are a couple of things that we're looking at besides what I already mentioned. Okay, so I'm cognizant that it is 4:53. And so I have a couple of wrap-up slides, just things to kind of ponder and talk about. So, so far with just these 2 studies, and we're doing some other work, you know, in this, you know, line of research, but you might be thinking, well, okay, you're talking about increasing ecological validity of assessments, but what you're doing is still really different from everyday life, right? You're asking people to name single pictures, either on a smartwatch, which is frankly kind of weird, and then also, you know, naming pictures in kind of a very traditional picture naming paradigm with FNIRS. But it's pretty different from this, right? Like this is everyday life, this is conversation, this is communication, where it's beyond the single word level, it's connected speech often. And it's often dyadic, right? Or you have multiple communication partners. And so this is, you know, where I want to build up to. This is where, you know, I want to go with this. But we're, you know, beginning stages on kind of the other end. And then this is, I think, the last slide that we have. You know, this is something that I've thought about too, which is that there are these wearables, these wearable technologies, whether they're neuroimaging systems or you know, these wearable sensors or smart devices. So it's a lot of new tools to play with and a lot of new methods that we can apply to studying aphasia. But there's a lot of work to be done to validate the use of those tools in both the controlled settings and then actually testing them in clinics and homes for our folks who have neurological disorders. And then, of course, we also need new methods for analyzing data, especially as paradigms get closer and closer to real life. Those are complex data sets that, you know, the more variables you measure, the more ways you have to try and incorporate all of the data. And, you know, I think it's exciting that now people are using like LLMs, you know, applied to neuroimaging data, you know, ASR for speech data is something I'm very excited about, considering that from the smartwatch study, I think we had, I guess, 1,200 naming responses per participant. That's really, really time consuming to do all that by hand. So a little bit of help from an ASR would be fantastic. Okay, so I'm going to stop there. I'm going to just, you know, thank folks in my lab and folks in Stephen's lab, of course, Stephen too. He's my collaborator on the smartwatch study, our funding sources. Then, of course, thank all of you online as well, and everybody in the room too. Hello.
So we have a bunch of questions, but maybe we should so if you want to ask a question online, maybe please unmute yourself.
Unmute or chat?
And you can post in the chat and Erin will read your question aloud.
Yeah, I can do that.
I have a whole bunch of questions, but I want to wait for other people to ask it.
I have 4 minutes to ask them. No, just kidding.
Well, okay, let me start off. Have you thought about, this is an easy one, low ball question.
Oh, God.
Have you thought about combining the watch
Oh, yeah.
recording and FNIRS together?
100%.
How would you do that?
So, yeah, so it's funny because that's something that I've talked to Stephen about some, and that's exactly what I want to do. In that I think what makes the most sense to me is that if you schedule like a long session for a participant to come into a space, there's a space at Northeastern that's, I think it's called the Home Lab. I'm being recorded, so I hope that's right. Where it's basically, it's like an apartment. And so we could set up like, you know, we can have like certain activities that we can do with participants while they have the watch on, while they have the FNIRS cap on. And so, and they'll just get pinged on the watch. When we did the at-home EMAs, we had like a rule where people couldn't there had to be at least 10 minutes between prompts. But when we were doing the training, the prompts obviously came like a lot more frequently because we didn't want to just wait around for 2.5 hours to just get 9 prompts. And so even just kind of anecdotally, like in the training session, you know, people are getting prompted quite often. And while they're doing that, we're still like just chatting with them, or like we walked to like the NU bookstore, and even with like higher frequency prompts, people were doing really well at answering them. And so that's kind of what I'm thinking, like it would.
I was actually gonna ask, like, how long was the longest 9-item recording that you got audio? How long would that be?
90 seconds.
So you could potentially record audio conversations for 90 seconds and maybe even longer, right? If you
Yeah.
expanded it.
Yeah.
So it's not
Yeah.
just, the nudge is a EMA thing, but the actual data you collect on your phone could be a longer audio sample.
Maybe. I mean, the one thing with this kind of work, especially with audio recording, well, in the lab, fine. Out in the real world, the problem, of course, is that like you're not just recording participant, but like you can get, although you can't really tell what most other people are saying if somebody else speaks on audio, unless obviously like the spouse is right next to the person being like, hey, like respond to the watch. So in lab, yeah, it could be longer. Yeah. I think it would be tough to get through an IRB with, you know, good reason, if it were longer, like out in the real world.
Okay.
Got a question. Oh, I do have a question.
That's a comment, I think.
Oh, no. So many considerations with real world audio recording. Yes. Thank
Okay,
you.
can we, maybe, are people waiting for me to stop talking to ask a question?
I have a question. So related to
Okay.
the first study.
Yeah.
So I'm really interested in sort of the like emerging trend that there's lower accuracy for the EMA versus the traditional
Yeah.
assessment. So I'm sort of thinking on like, they're not directly applicable, like you mentioned, but sort of thinking on like, if you administer the Boston naming test without the stop criterion, right? People are naming 60 items.
Yes. Mhm.
On one single day for your participants, regardless of condition, they were saying 36, so about half, right?
Mhm.
But do you get the sense, or maybe your intuition, or could you speculate that sort of this repeated prompt is more fatiguing? Like, could that be a reason why people might perform worse on the EMA than they would in the traditional assessment? Or do you actually think like a huge block of naming in that way is better? Or maybe it's not about fatigue at all. Maybe it's like something else that drives the difference between them.
Yeah, I mean, so the fatigue question's a good one because, so I don't think the act of answering is fatiguing. I mean, actually, I think that, I think honestly, like giving a 260 item naming test is really fatiguing, right? Like you've done that. I mean, when you have people with aphasia by like, you know, item 100, they're like, when is this thing going to be over? So it's interesting that the accuracy is actually higher, you know, for the traditional. So I don't think it's actually the act of responding and like doing the EMA that's fatiguing, but I wonder if there's any effects of like naming later in the day. And so that's something that we haven't looked at yet, but I'm going to. I'm really interested because that's obviously something that our participants and our patients report all the time, is that as like they're going throughout their day, like they're doing all right in the morning, and that afternoon they've just, you know, kind of reached their capacity.
I had a similar question. when you showed that slide, but I kind of was thinking the opposite, like maybe when you're in the lab giving them an actual assessment, people are probably like trying to really get it right, but like you're sitting there, you just get a prompt at your watch, you're like in the middle of your work, you're like, oh, let me just, I'll say something. If I get it wrong, oh well, I'm gonna get 30 more of these today. It doesn't really matter.
Yeah,
So maybe are people like just not taking it seriously?
I don't think so. Based on knowing these participants, I mean, you know, the folks that we had in this study, honestly, are like the people who've done a lot of our research studies, you know, they're the folks who are like, oh, I really care about research, I'm really invested. And you can like hear them, they're really trying on the watch. I mean, but it's an interesting question, maybe about a condition difference, but certainly like a participant difference, right? I think this is where like those personal factors kind of come into play, where you have like, you know, the one person who's like, I'm going to try and name spider for the next 2 minutes. You were going to give me 2 minutes. And you're like, I don't know. Are you going to retrieve it? I'm not sure. And then there's the person who's like, nope, I know it's not coming. Let's just move on. So I don't know. Again, I don't think it's like a condition difference. I mean, I don't think we have, I think the people who like are the ones who are like, I really want to get this right in front of the clinician also are like, I really want to get this right on the watch too.
You looked at if the accuracy changes over the course of the study, like if they start out higher and get lower or stay the same?
Yeah, so I have actually. And so the interesting thing is that there's a slight uptick, a slight increase in accuracy.
But they might also be learning the words.
Yeah, well, so it's like maybe practice effects, right? And so that's kind of an interesting thought because some of the feedback that we had from the participants were like, oh, I think I have on the slide, like, I like the pictures. By that, they're like, I like naming the pictures. You know, it's, I feel like it's practice. I feel like it's kind of therapeutic, even though, you know, it's not therapy, but just like that consistent practice, like some people enjoyed that.
Did you specifically tell them not to like look up?
Yes.
Okay.
Yes. I mean, I do have to acknowledge that there were at least a couple participants who were like, no, please do not. You know, because we had these check-ins with them. So we had these weekly scheduled check-ins with them, but we also obviously like said, oh, if you have any issues, feel free to reach out. And so we did talk to the participants quite a bit over the course of them doing the experiment. So when people said, oh yeah, I've actually looked up these items, you know, so we've, you know, we noted that, but we told people not to.
And for the burden question?
Yes.
That was that done once at the end of the study, or did you sort of like ask questions throughout?
Yeah, so we had these weekly check-ins, and so with folks with aphasia, there were Zoom check-ins so that we could like, and so they did the survey at each check-in. So it was three surveys.
But there was no other like daily like mood check-in or anything like that?
No, and so that's something that I talked about with Stephen quite a bit, like when we were devising the study, like very beginning, like I really wanted to have like an extra question about like, you know, rate your communication right now, or like, or even just like, how are you feeling or something else. But the thing is that we wanted to keep it like very simple for this study where it's like, they always knew what to expect. It was always just the exact trial flow and we're not throwing something else at them. But that's something that I'm thinking about for like a larger scope study, where to get more information from them, either from additional sensors or from other types of EMAs. Yeah.
I just want to make, if anybody online has a question, please either raise your hand or type it, because we're just chatting here and happy to take questions online.
And people can also email me if they have any questions or thoughts. I'm happy.
Did you notice any lack of consistency within an individual in terms of their responses? So did you find if someone gave the wrong response, did they repeatedly give the same response, or did they try to adapt their strategies as they saw the same item?
So I was wondering if somebody was going to ask that because like I kind of like frame this all like, oh, hey, we could look at variable access, and I haven't looked at it yet. Mostly just because it's so time consuming to do all of the transcriptions and coding. I mean, shout out to my students, like for all of the work they've done on this, Skylar especially, like good work if you see this. Because it's so time consuming, but that's something that I'm really interested in. I'm not sure if we're gonna get to drill down to sort of like, I don't know, like the quality of the response, but we can certainly look at for the same item, the consistency in their naming, because 756 divided by 108 is 7. And so they were scheduled to see each item in their naming set 7 times. No, that's wrong math.
Was it a different set every day?
So they had, so they saw 36 pictures, they were scheduled to do 36 pictures per day. And so they had different pictures, each, like day 1, day 2, day 3, and then it repeated, but it was random without replacement. Is that the right term? And so like it would cycle through all 108 pictures before restarting in a random order.
I had a question, slash comment. Have you thought, and maybe this is something that you would want to incorporate in a future study, just thinking more about like way down the line of using this in an everyday setting. Did you collect any information on like if someone pressed no, like why they pressed no?
No. No, I mean, it's a good question because one thing I'm really curious about is like what is happening in that moment when they're being asked to do this? Like, who are they with? What are they doing? How are they feeling? You know, like all of these other reasons why somebody might not respond. I mean, I know just personally, I mean, we beta tested this app extensively before deploying it, multiple different versions. And so I think maybe I was probably around some of you at some point when the watch went off that I was wearing it. And so there were so many reasons why I didn't respond, right? And like the reasons why I didn't respond might be very different from somebody with aphasia who doesn't respond, which might be different between people. And yeah, so no, we don't have that information right now. It's a good question.
You talked a little bit about environmental factors as some of the variables to look at.
Mhm.
Do you have access to any sort of variables? So what I think about is, for example, like smartwatches, some of them can actually collect data on loudness
Yeah.
in the environment.
Yeah.
So have you looked at any of those variables in relation to prediction of naming accuracy at a given point?
Not yet, but again, it's something that we want to do. One thing with this is because, so what we tested before we deployed this is to make sure that people could be heard. Like, so Stephen's PhD student, Jack, who did, he created the app and he was really driving it. I think when he took the watch like and stood on like a busy street here in Boston, on the sidewalk, not on the street, but and you know, he tested like different distances and when it could still be audible. So the challenge with that, and I think the issue is because it's a watch, and so like the distance between like somebody's mouth and where the watch is and where the recording's happening is different between people. And so that affects, you know, kind of the difference in like the loudness of like the person's voice versus background noise. Like the closer you are to like the mouth, like the harder it is, I think, to get like an accurate like assessment of background noise.
Interesting.
Yeah.
Maybe you have to have people give a bunch of samples at a certain distance and then do some sort of geometry.
Yeah, we've talked about like headsets, incorporating like headsets into this, but which is like a thought too, but then it's like a little bit more cumbersome, and that's something that we've thought about, because then it's always like the distance between the mouth and the microphone is always the same. And then I think then the recordings would be a bit more reliable. But I don't know, I think it's something maybe we can revisit. I mean, something I thought what you were actually going to ask is like, you know, I've gotten a few questions about where people are, like the GPS built into the watch, which, you know, I like your question too, but like,
Seems more invasive.
yeah, I mean, it is. Well, so there's a way to do it. And so you don't have to, yeah, you don't want to like just be tracking everybody around, but like if you have like a list of like common locations that people visit, you can kind of triangulate so you can get like a location that they essentially provided you. So it wouldn't be, you know, complete, but it's not as invasive. It's just like, you know, following people around. But the problem with that though, is it also drains the battery life really quickly. And so adding that to this when we already have battery life issues, makes it more challenging.
It'd even be interesting to know if someone was in motion right before the prompt, was
Yeah, this is
administered.
ecological
versus, like, just-
Yeah, exactly.
That's what. As a proxy of anxiety or,
So we turned it off for this study because that drains the battery super fast. So that's an issue that, I mean, that's not gonna solve it, but that's something that we talked a lot about over the whole course of the study. It was just what can we turn on and turn off to maintain the battery for as long as possible for like the thing that we absolutely need. And so we're thinking about like other watches, other devices, or you can also pair it up with other sensors, right? So that's a possibility too.
Can I ask you an FNIRS question? But I
Yes,
feel like
please.
people should feel like they should drop off because it's 5:12.
Everybody like online.
Yeah. But why are you surprised about the decreased activation in the patients? Isn't hypoactivation or decreased activation in patients with aphasia?
But it's relative to
expected.
rest, not.
But it's relative to rest. I
Yeah,
think
they're
that's
not
the
the
thing that's
healthy
getting
controls,
me.
yeah.
I mean, it's relative to rest and it's also relative to controls, right?
Oh,
So it
okay,
is
yeah.
decreased.
No, relative to controls is what I'm asking about. I'm just not sure rest
Yeah.
was the right baseline.
It's
there.
not. So this is the challenge with this task, and this is something that we wanted to pilot, and frankly, we're just adding this to an existing pipeline where we are prioritizing other tasks. So we didn't have like a low level baseline to compare it against. So that's one of the big issues with this task. I don't think comparing to rest is the best way to go. I don't. What I did do is I actually analyzed the data also by essentially using silence as the baseline. So just saying like, basically
The control condition.
as the control condition, because that's really what we're getting at, right? Is
I was gonna suggest that you do that because
Yeah.
you have silence as your initial condition and then you see what you get, because otherwise you don't know what they're doing at rest, and
True.
compared to the controls, if it's anywhere reduced, then you've got something to bank on.
Yeah, I entirely agree. And in addition to that, like our rest period is not really long. So we're basically saying like, what is going on for these conditions compared to not much time where we
Yeah,
don't
and-
really know what they're doing.
And they could just be getting off the.
Yeah.
F signal. And thank you, everybody, for
Thank you.
joining. Those of you who stayed
Amazing.
15 minutes longer.
I know, thank you, everyone.
Um,